Security session here at Spotlight Health. It's early and we're so happy you're here. This session is a reflection of a community of people, experts in global health security really, hosted here at the Aspen Institute that has met for the last 3.5 years to take ideas to action from Spotlight Health. And it's called the Aspen Ideas Incubator. And we focus on health equity and how we reach the hardest to serve. And this year, we took a real deep dive into global health security and how we think about that framework while holding equity at the center of it. And the people here on this panel today were all at that incubator yesterday. I want to give a special shout out to Ken Davis and Prabhat, Mount Sinai's Arnold Institute for Global Health was really, David Berman back there, was really visionary in helping to support make the incubator happen. And together, our partnership reflects this notion of something Walter talked about on the stage last night at opening, which is how do we take all the amazing ideas here and really drive action towards the injustices that we're trying to solve in the world. So with that, it's my great pleasure to introduce Vice President Peggy Clark. She also happens to be my boss. It is not every day you get to work for a brilliant person who also is incredibly kind and treats everybody she comes in contact with the sense of, equity and humanity. So it is my great honor to introduce Peggy.
Thank you, Katie. Great. Good morning, everyone. It's a delight to have you here with us. This session is called Building Global Health Security from the Ground Up. I have the privilege of sitting with actually my heroes up here in every way. And so I'm going to dive right in because this is a really fascinating topic. And let me first begin by introducing my panelists who are remarkable individuals. And let me also welcome those who are watching this on live stream. We're very delighted to have you with us. First, let me introduce to my left here, Chris Kirchhoff is one of the 4 partners overseeing the Pentagon's Silicon Valley office, which is a kind of an interesting thought. We don't know what the Pentagon's Silicon Valley office looks like, but we're all very curious, right? And it's called Defense Innovation X. It's a $100 million investment portfolio. Chris, we're delighted to have you with us. Thank you very much for your presence in the Ideas Incubator. And then we have Dr. Ngozi Irondu, who is in a beautiful red dress. She's an assistant professor at the London School of Hygiene and Tropical Medicine and the co-founder of the Global Bridge Group. She's also an Aspen New Voices Fellow. We're delighted to have you with us. And Ngozi brings a really important perspective. She's been on the ground working on a number of the key issues, H1N1 in Saudi Arabia, the beginning of addressing the Ebola crisis in Guinea. And she's continued her passion about this work for a long time, so welcome, Ngozi. And then we have Dr. Prabhat Singh, who is immediately in the middle of the panel in the beautiful blue suit. Prabhat is a dear friend. He is a brilliant thinker, and Ken Davis says he does many of the things he does because of listening to Prabhat, which is pretty wonderful. He's director of the Arnold Institute for Global Health, and he chairs the Health System Design and Global Health Department of the Mount Sinai Health System. He combines systems engineering and social mobilization principles, and it works very hard on how the U.S. healthcare system could learn from and benefit from examples we have in the developing world. He also was a founding technical advisor of City HealthWorks in Harlem, a really interesting new approach to delivering the hardest to serve in low-income communities in the U.S. He's also the author of Dying and Living in the Neighborhood, a really wonderful book, a street-level view of America's healthcare promise, which we have in our bookstore, which is right down there, and he may even be doing a little bit of a book talk. So welcome, Prabhat. Thank you for being with us. And then another hero right here, the dear and beautiful Dr. Agnes Biniwanho. Agnes is the former Minister of Health, the Minister in Rwanda. For those of you that don't know, Rwanda is a miracle. It was, as you know, a country experiencing huge challenges after the genocide. It is now an incredible global success story. Rwanda is one of the only countries that met every single one of its Millennium Development Targets. In many ways, the successes they've seen in reducing child mortality, maternal mortality, vaccinations are due to the bravery and courage and tenacity and life force of Dr. Agnes. We're delighted to have you with us, Agnes. I hope you're having fun here. We've been trying to get her to Ideas Festival for a few years, and yay, she's finally here. And then another hero at the end of our panel is Dr. Raj Punjabi. Raj is the founder of Last Mile Health. He is also a hero, like everyone on this panel, and he is a Liberian who went back to his country to begin a project that focused on community health work at the very last mile in Liberia. Raj is the recent recipient of, I just was joking with him out there because he is the recipient of the TED Prize this year, which is $1 million prize for his work with Last Mile Health, and also was named one of Time Magazine's 100 most something people, important, influential. But he is a very humble person. And just when we were standing out there, he said, oh, Richard something. And I was like, Richard who? He said, Richard Branson. I'm like, okay, we're going to go hang out in a really sleazy diner so we can bring you back down to earth. But Raj's work is profoundly important. And Raj, along with everyone on this panel, were involved in a day and a half of deep deliberations about how we can reach the hardest to serve with community health to address the challenge of global health security, which affects us all. So let's just dive in. We're going to save time for questions. We really want you to be involved, so just think about what you'd like to ask. But let me start with Chris, our Silicon Valley defense expert. What's global health security?
So for me, it's a very personal thing. Before I was working in Silicon Valley, I was working in the Pentagon in the summer of 2014 as the senior civilian advisor to the chairman of the Joint Chiefs of Staff, the head of the US military. And he asked me early in that summer to keep an eye on the Ebola outbreak in West Africa. We were both worried that this could turn into something that maybe even the US military would have to help address. And as the summer went on, I spent a lot of time with the chairman, introducing him to terms like zoonotic disease and animal host reservoirs and R-naught, the mathematical measure of the spread of epidemics. And that summer it became abundantly clear to us all that Ebola was not only in danger of spreading across Africa and possibly becoming endemic there, but actually exporting itself to other places in the world, possibly causing a massive economic dislocation and a very serious threat to the US homeland. So for me, my personal definition of global health security is never again finding ourselves on the brink of such a global catastrophe. There's two other things that I think about when I think about global health security. The first is, unlike a lot of issues that I've gotten a chance to work on, this is an issue that's actually solvable. We actually have, thanks to the dogged research of the brilliant colleagues of mine on this panel, a set of approaches that could make measurable progress. This is not an issue that you have to invent cold fusion to make it work, if you will. So, which is incredibly inspiring. But at the same time, I worry that we're at a moment where the urgency we all felt during the Ebola outbreak is dissipating, and that there are dynamics working against our attempt to give this issue the amount of resources that is cognizant with the truly enormous threat that it poses to all of us. So I almost think it's time for a kind of new consensus to be built, because I think there's so much more work that needs to be done for us all in this area.
So Chris, part of the Ideas Incubator is to come up with ideas to action. We cooked up some really interesting ideas. What's one thing you're really excited about from the incubator that you've been thinking about since you left it?
So I've been thinking a lot about what a new coalition might look like. I mean, as we all know, right now, many nations, around the world are turning inward. There are funding sources for global health that are currently under threat. It would be an understatement to say that the U.S. Congress this week has other priorities on health. So I think it's going to take a really neat blending of people who have lived this with people that have other skills of how to tell other people meaningful stories about what's at stake here, and to build a coalition, a campaign that will do this issue justice.
That's great, yeah. Well, I think it's interesting, global health security is kind of a funny acronym in and of itself. So let's unpack that a little bit. And Raj, let me turn to you. We began the incubator with Raj Punjabi talking about the Ebola outbreak from the perspective of Liberia. and former CDC Director Tom Frieden talking about the outbreak of Ebola from his perspective, being responsible for dealing with it at the highest level of policy. Raj, tell us what global health security was to you, and a little bit about how you told us the story that you experienced.
Sure. Well, I think there is a risk of, as Tom said so eloquently, an EIO syndrome. Ebola is over syndrome across Africa and other parts of the world. And we've seen this with so many other crises. You know, when a crisis strikes, we're much more engaged when we can see the fire in front of us. To keep the fire at bay, to prevent it from happening again, is much more challenging. What we learned during the Ebola crisis, I was working with my colleagues in Liberia in rural areas, and had seen that the courage of community health workers to respond was quite tremendous. I think very clearly they made it apparent to us that we as human beings are not defined by the crises that strike our lives. We're defined by how we respond to them. At the middle of September and October 2014, we had been working in a remote community in an area called Riversess, where a 40-year-old woman had moved from Monrovia back to her family with the Ebola virus, had died, and deep in the middle of the rainforest, 14 days later, 14 people who attended her funeral had also died. Of course, this disease transmits from person to person, and the community had had no health workers present. And by the time this community, where there had been no electricity, no roads, no cell phone communication, was able to alert the public health authorities, it had already started to spread from one village to another. Well, at that very moment, we were told that there could be as many as 1.4 million cases by January of that year, and if nothing more was done. The good news is that there are effective interventions, and these health workers are a part of that solution, investing in local health workers. So when we heard those projections, when despair was at, I would say, its highest, when we had nearly lost all hope, we didn't see community health workers surrender to fear. They answered the call to serve their neighbors. They went door to door in that community to find the sick. I can remember a 24-year-old who donned the gloves, the masks, the gowns. A guy named David took the very dangerous task of taking a syringe and a needle and going door to door in that community to draw the blood samples. You can imagine how risky that is, given how easily transmissible the virus can be when you're in contact with it in a blood specimen, and how lethal it could be. He went door to door to get blood samples, get that into a lab so we could figure out who was sick and who wasn't. Within a few weeks, they had helped control that epidemic. So to me, what global health security means is investing in local healthcare workers and in the health systems that are needed in those places, so that in rural areas where zoonotic transmission can happen from animal to human, but also where human to human transmission happens with these epidemics. I would say that the second big lesson we learned is that blind spots in rural healthcare, when we don't invest, can lead to hotspots of disease. In fact, the cost of inaction on this issue is much higher than the cost of action. And so we need to keep that going so there isn't an EIO syndrome going forward. And I think it's a very hard thing to do, but it's possible.
Right, great. Dr. Agnes, let me turn to you for a minute. You were part of the solution. And we saw last night the beautiful film Bending the Arc about partners in health. And a part of it is filming Dr. Agnes as she's trying to find out whether Ebola is spreading in her own country. So tell us what you think the solutions are. And you've traveled all this way to come here, and you are not shy with telling us what you think the global community and many of the people here today need to do to address this question of global health security. So tell us your perspective on that and your own experience.
First, Ebola didn't spread in Rwanda.
Right.
We were lucky. I don't see that we were lucky, because the country that suffered did nothing to do for that. However, they were not prepared. So what we did didn't start at the moment of the danger. What we did was to protect Rwandan by providing basic care and create a system based on equity, meaning each village received the same, each district received the same opportunities that the country has. So when we have such a system, we have already created a trust that the government is there to care. And the population trusts the government. And this is a key component in the middle of the chaos. Because people are so scared, health professionals are so scared, our neighbors are so scared, that we need a force that brings everybody together to do the right thing at the right moment. So building a protection, an additional protection in case of a danger like Ebola, it's easy when you have when the basis is done. And, and to be prepared, it's a lot of work, a lot of coordination, a lot of organization, and it's also leaving no constituency out, no partners, because every ideas, every support is needed, but also make sure that each and every Rwandan, in my case, it was Rwandan, is informed about what it is the risk, what to do in case of risk, and giving the message of, if you come to us early, we have 70% chance to save you. If you don't, you have 70% risk to die. And explain that, but also make sure that you have point of care. Don't create mortuary, meaning you are sick, we put you there so that you protect the rest. No. You are sick, we put you there, and we care. We do the maximum we can. So that means your chance is to collaborate. The chance of everybody is a national collaboration. The chance of every country, it's a regional collaboration. So global security starts where we are, by protecting your neighbor and protecting your nation, protecting your region, and protecting the world.
Beautiful, thank you. Ngozi, let me turn to you. Beautiful, thank you. Ngozi, you've talked about, you have been one of the people on the front lines dealing with this, but you've also talked about the role of storytelling and how one of the things that came out of the Ideas Incubator is, I think, this idea of creating a new narrative around what needs to be. Tell us about your thoughts about that.
Yes, so I love the incubator because we were in this room with so many different people, and one person that was in the room was Mark Henderson of the Wellcome Trust, and he's the communications director there. And he talked a lot about having a common voice when we're talking about pandemics or we're talking about prevention or outbreak control. And that's very important. You know, I think most of us here, we don't just sit around and talk, oh, hey, how was the pandemic? We don't usually talk about it. That's not something that's normalized yet. But if the folks up here, the scientific community, researchers, if we have a common voice, a common message, so that we're able to talk about preparedness before outbreaks, but essentially also during outbreaks, then the population, the public can receive that better. They'll be able to receive messages about how they can protect their individual security. And like Dr. Anya said, you know, your individual security, once you protect that, you're able to protect your community, the nation, and the world. And this is really effective for the UN He for She campaign. That was actually started by a Zimbabwean activist for gender equality. And it was this concept of empowering and engaging young boys and men to be the drivers in women putting women first and protecting women's rights. And feminism was there before then. Other initiatives were there before, but this was this new concept of putting that responsibility on to men and having them be advocates of women. And that one voice, that common voice, that was taken up by different organizations and different programs. A lot of us here have heard that. 2014, Twitter said that that was one of the most catalytic messages of 2014. And so wouldn't it be wonderful if we can do the same thing for global health security? So.
Yeah, that's beautiful. Let me ask you, a follow-up question here. You were given awards for your role as a CDC epidemiologist in Guinea, working on the Ebola crisis. Why did you decide to go into this really hard work? Why were you on the front lines? Let's try to make this a little more real. How did you decide to take on that role that you took on?
Well, I think it's just a privilege to be able to work with frontline healthcare workers, and I had a history of working with polio eradication. So I already knew the field. I knew the folks that I would be out there with conceptually, because it was my first time in Guinea. And when the outbreak was at its peak, at its worst, I was actually studying for my doctorate, and it just really hurt me that I couldn't be part of that response, because there were certain periods throughout the outbreak where they didn't have enough health personnel, and I really wanted to go and lend my skills. And so as soon as I finished, I went out with CDC to be a field epidemiologist, and it actually, at that time, the outbreak was declared over already, so I was actually going in to help with strengthening surveillance systems and training health workers and things like that. But while I was out there in March of 2016, we had a flare-up of some new Ebola cases in the forest region of Guinea. And so then I was part of the response from that situation.
Right,
Yeah.
Wonderful, thank you. Prabhat, you're really at the cutting edge of some of the most innovative thinking about how we can address this challenge. And in particular, I'll never forget the first time you showed me Atlas. So will you tell us a little bit about the Atlas approach to surveillance? And then you also uniquely sit on this panel in crossing between global and US. So tell us a little bit how a tool like Atlas could be useful to anyone, anywhere.
Great, thanks so much. I think this panel itself is a great representation of just when you enter into a pandemic response situation, how many different layers of people have to be involved in a fog of information. We have Chris, who has to think about large investment allocative decisions. What is the zone that we're working in? What's the big territory? We've got a minister that has to think about all the layers of the health system that need to be coordinated to deploy action against. We've got people like Ngozi, who have to think about the technical elements that you need to drive a response. And then Raj, who's thinking in the community and frontline interface of what do you need to do. It's a huge amount of information that has to somehow be put at your fingertips, assembled in the right way at the right time to be able to drive a coordinated response. And so, one thing that we think about in terms of a discipline of how we're thinking about Atlas, which is a platform to help give the right information to people where they are, is that in a response, you've got to first narrow down the zone of where are you working. Now, if you're in the US, in New York City, we want to narrow it down to blocks. If you are in West Africa, you're narrowing it down to whole regions, countries. And then you have to deploy resources against that in settings that are already resource poor. So you've got to be able to narrow it down. Then you've got to figure out where do you not know what is going on, the blind spots. We call them the cold spots. You need to know before you get to the analysis of the data, where do you not know critical information, and you need to deploy people against that. And once people are there, they need to have enough context for what's happening in the community and the front lines to be able to act. And so what Atlas ends up doing is bringing together the latest in satellite views and machine learning technologies that start to bring up ground information and put it on a map. It also starts to highlight where are the places where there's no information. So you can start deploying resources against that. And then once you're on the ground, instead of just being a health worker who's alone in a rural and remote place, you want to know what are the 500 other colleagues that are also alone. How are you connected? What are you collectively seeing? What can you do based upon that information?
And so Atlas is a system to kind of bring that together. And sitting in New York City at Mount Sinai Health System, which is the largest health system in the city, we are at the center point of global interactions. JFK, off the airport, comes to one of our affiliates, and I train there, and it's an incredible place to learn medicine because of just the world comes to New York City. But it also means that we have to be prepared, and that preparation can't be something that's completely different from our everyday work. And so the way that we think about Atlas is that it has to be incorporated into how a health system usually works. And when you have a surge, a demand for all sorts of information coming together, it has to come to the people that are going to be making the decisions and acting at their fingertips. And I'll say that the incubator has been formative for us because we presented the Atlas concept last year at the incubator, and USAID immediately supported us through their Zika pandemic fund and future threats fund. And we were able to begin the building of this platform in Guatemala, starting it in the US, and I'm going to be going with Raj in August to Liberia to start looking at how that might connect. And you have a New York City, a Guatemala, a Liberia, and you have the starts of a platform that you can imagine growing to have both a specific use and a general purpose.
Right. So that's one of the tangible ideas for investments that came out of the incubator, which is terrific. And I'm hoping we can bridge a little bit to the audience here, and let me come back to you, Chris. And let me ask you two questions. Why should the people in this audience care about global health security? And then from your vantage point, having been at Department of Defense, what is the role that the U.S. government should play in this challenge right now?
So why everyone in this room should care about global health security is had the global community waited about another 4 weeks to act in probably September of 2004, there's a very good chance we would all be sitting 1 meter apart in this room, because that's the safest distance you can be away from an Ebola patient without a low risk of transmission. So this is one of these issues that it's bigger than a war. It is hard to understate how serious an issue this could be for all of us.
And the second question was, what do you think the U.S. government should do now? And what's your kind of assessment of where we are in relation to what we should be doing?
So we learned so many lessons about what's needed to mount a response at scale. And there's some interesting things that we learned. So one of the things we learned is that the parts of the U.S. government that have the most knowledge of how to respond effectively have the least capacity to deploy overseas. So if you look at, for instance, the Center for Disease Control, the Public Health Service, USAID, you're talking about hundreds of people perhaps that you could send abroad. There are over 1 million U.S. active duty uniformed troops. So we faced the challenge of learning how to work together. And we had never worked together before on a health response. And what I worry a little bit about is, unless we continue working together in training exercises and building the infrastructure to be able to deploy rapidly, to have a cookbook, if you will, a playbook of what we're going to do. By the end of the Ebola response, we were working together so well, not only the U.S. government resources that were involved, but matching that up with what the UN brought to the table, with what so many host country governments brought to the table, what so many private sector and philanthropic organizations brought to the table. And so I worry that we're not getting together enough.
So the coordination.
Exactly.
What about the potential cuts in the budget that we're hearing about, and how that might influence our ability to be a global leader on this?
It worries me terribly, because if you think about the consequences of what could happen if, one of the most surprising things to me as a not somebody who's a trained epidemiologist is, Ebola was actually one of the easiest cases. It's not transmissible by air. The outbreak happened in a region of the world that has minimal air connectivity. And even then, it almost became a global catastrophe. So I worry terribly if we don't make the investments that are needed.
Yeah, right. So let's talk about community health workers, and let's talk about the idea of the last mile, which I think everyone on this panel, and it was a big piece of the discussion, is a very important piece of the puzzle. So why are community health workers important? And I wonder if, Raj, you could start us off, and then Agnes, you could jump in a little bit and tell us how they have been such a part of your vision for Rwanda.
Thanks, Peggy. And first I want to commend Aspen for putting such leadership and focus on the challenge of last mile communities, whether it be remote, rural, or in urban areas, and also focusing on community health workers. So community health workers, of course, are middle to high school educated members of the community that are recruited, trained, and equipped with medicines to go door to door to serve their neighbors, often in underserved communities, whether they be in urban slums or in rural areas. They're critical in the case of global health security because we know from the very first child that was struck with Ebola, patient 0, Emil, who was struck with vomiting, fever, and diarrhea in December of 2013, died. A few weeks later, his sisters died. A few weeks later, his mother died. That disease spread for almost 4 months before, in March 2014, it was picked up as Ebola. By then, in an area where there was a massive shortage of health workers in the dense rainforest, the virus had spread like wildfire across West Africa. Millions of cases were potential. Thousands of people died. Millions and billions of dollars was being lost. We were already too late when every minute had counted. So who will be we can't predict when the next outbreak will happen and whether that next outbreak will be Ebola or whether it will be Zika or whether it will be, as in the past, HIV. All three of those viruses started in remote rainforest communities in West and Central Africa where there is a lack of health workers. So community health workers, workers like David, who I just mentioned, the 20 or 4-year-old who went into the community, are absolutely critical to helping first be the eyes and ears of the health system to detect when a little boy like Emil dies from a mysterious disease. Imagine if there had been health workers there that had been better equipped, connected to the healthcare system, and they would have found that this boy was sick earlier, and the system could have detected Ebola earlier. How many more lives we could have saved, how much less destruction could we have had? I think the big question to us is, are we going to be conscious of little boys like that or little girls like that or families that are vulnerable in areas of risk? And whether we will do something now before the next outbreak happens. And so community health workers are critical to that. The challenge, of course, is that they don't get as much investment as is needed. Yeah. And so, and countries like Dr. Agnes's in Rwanda have shown that when you do put an investment in, you get tremendous results.
Yeah. Dr. Agnes, tell us, why are community health workers important?
They're first of all important because they manage more than 70% of household burden in normal case. So if we lose them, imagine what we lose. That's first. Second, they're on the front line on any surveillance system. Simply with a little phone, $5, they can send an SMS when there's something wrong in their village so that they can alert that something should be watched by the national lab. So they are our soldiers in front of any health threat. Third, they have the trust of their community. In Rwanda, they are elected by the village, and the Ministry of Health is in charge to educate them. They have the trust of the village. We can be in touch with them by a simple SMS sent to the 45,000 of them. Be careful, there is a cholera outbreak in East. There is this in, etc. So they inform and relay the message better than anyone. They help the health sector to contain with the trust of the population, meaning the people will follow the guidance because of that. So they are important at all levels.
Good, beautiful. Thank you so much. So let's talk a little bit about, in the Ideas Incubator.
But if I can add
please,
something to the question why we should all be concerned here and all those who follow us in internet. Health threats kill more than any war on us.
What did you say, health threat?
A health threat,
a health
yes.
threat.
Killed more every year If you put
Yeah.
tuberculosis, malaria, Ebola, and all those things, there is more death preventable
Yeah.
by all of us than any rebellion, war, terrorism, and all those things. So we better be concerned.
Well, and it turns out, as far as I've seen in the medical literature, there's no peer-reviewed science that backs the idea that you can bomb Ebola. You can't bomb Ebola.
Yeah.
You can't build a wall against Ebola. You have to be able to invest in these frontline health systems. So the good news is, as Chris has pointed out, there are effective ways to do this that cost a lot less if we do it now than when these outbreaks emerge.
Yeah.
So.
I want to get to some of the action items and ideas that came out of the Ideas Incubator that are really tangible and ready to go. But before we get that, I'm very aware of the fact that you guys are really at the front line, and we're sitting here in beautiful Aspen, and many people perhaps only heard about Ebola as it relates to really being very fearful about it coming. How can we possibly, in this moment, when we've become more isolationist, how can we possibly make this sort of moral bridge? And I know that's a little bit of an intangible question, but I think you guys know what I'm getting at here. Pabda, let me start with you.
Thanks, Peggy. I'll mention that there's one thing that's, I think, changed in the last few years is that the type of talent that's coming to solve these types of problems has really enriched. The team, for example, that leads Atlas come from machine learning and climate science. The people that work on the ground with the health workers are from product design and consumer interfaces. And they have come out of finance or ad tech because they feel like they want to be part of a mission-driven project and organization. So I think in some sense, our ability even today to assemble the team that can make something like Atlas possible and bring the talent to where I think it's the research and development to the last mile in these settings is something that has changed. And I think that actually, as Chris mentions, that we have an imperiled federal funding landscape, the importance of both private and philanthropic support for research and development is higher than it ever has been.
Right.
And in some sense, I think people feel that growing sense of responsibility for these types of issues. And there's a way to participate in it, which I think has changed.
And Ngozi, what do you think about that? You know, what is the moral imperative here, and how and why should we care about people on the other side of the world from here?
Well, most people that I've met, they're very charitable and humanitarian. A lot of people that I've met in my life just care about other people. And I think that, you know, in an atmosphere, an environment of fear, we do go inwards and that we shut that part of ourselves down. And we just need to not do that. And one of the ways to not do that is to really humanize that other person. Dr. Frieden was giving a very amazing presentation about the Ebola outbreak to the incubator people before we met for the incubator. And he was showing data points, and one data point, it said like grandmother, another data point said 8-year-old girl. And I remember that was the family that I had to see every day. I was monitoring them, looking for symptoms. And the 8-year-old girl had died before we were able to do anything. But I remember going and talking to her family members and the grandmother was so sweet. She always brought me bananas every morning. And I remember one day her eyes just looked very red. And the next day we took her to the Ebola treatment unit, and then the next day she died. So these are real people. And if we remember that they could be our sister, our aunt, our husbands, then I think as constituents to all of our governments, we would be able to really push the need for global health security, push the need for investing in low-income countries. So.
Beautiful. Very beautifully said. Thank you for being there. What are you guys most excited about that came out of the incubator that are tangible ideas that we can really invest in? Let me start with you, Agnes.
Idea that came yesterday is how we can collaborate, each and everyone in our capacity, to make things happen faster. Because in any case, it has to happen. But if we take the concept that suits some countries and that can be adaptable to other countries, if we take the opportunity to monitor, to follow those trends, if we understand the role of defense and the role of technology, how to use it to better coordinate, to be faster, to bring connectivity where we need to bring connectivity in case, and also to globally act quickly. And if we take like my university, where we can train the leaders how to do that in a coordinated and quick manner, to use all those, I think we can serve the world and make the world a better place. Yeah. And also remove the fear, act because I'm afraid to be sick one day, because America react like that. America entered in the game when case came in America. So don't act because you are afraid to be sick. Act because every life counts.
Beautifully said. Thank you. Great. I'm going to open it up for questions in just a couple of minutes, so get ready, and then we have some microphones, I think, ready in the back. Raj, you have one really big wish that came out of the incubator and also out of your own life, which is the TED Prize. Do you want to share that with us? What you're going to be doing?
Well, I think it comes back to this point about how do we prevent, detect, and respond to these outbreaks in not just the Ebola epidemics, but the everyday epidemic of premature death that exists throughout the world. And frontline community health workers are one piece of that. Well, how are we going to train a global army of local community health workers that can be on the front lines to respond, to save lives and also to keep everyone safe? Well, it's a real challenging thing to do. The world needs, we know Africa needs at least 1 million community health workers in rural areas. To reach that level of scale is challenging without having a platform to do it. Now, every country has got some efforts moving. We know there are 25 countries that recently met in South Africa to talk about how they could build national community health workforces. So our wish with the TED Prize, which was inspired in part by Walter Isaacson's work on the Innovators book, which is, I'd highly recommend, A History of the Digital Age, is the realization for me, look, I work in places where you have to take a canoe to go see a patient in a home. And these are places that are 1 billion people don't have access to healthcare, about 1 billion people don't have access to mobile phones and the internet. There is, if we do not argue for technology, this digital age that has only been a couple hundred years old, to be extended to reach all people, we will leave them behind, including in healthcare. So what we've put forward is the idea of a community health academy that would use this revolution in digital education, online courses, smartphone-based video and audio lessons, to transform the way community health care is delivered and how these community health workers are trained. So this is going to be a global platform to train hundreds of thousands of community health workers to save lives and provide health care to hundreds of millions of their neighbors, from the forest communities of West Africa to the villages of India. And that was one of the ideas that was inspired about a year ago from the incubator that we then had a chance yesterday to workshop, and a number of partners, including the Aspen Management Partnership for Health, have talked about, and colleagues from Rwanda and Malawi and Sierra Leone have talked about that being a potentially useful platform for helping those countries succeed.
Beautiful, great, beautiful. Let's see, I want to make sure we have time for questions. So we all have a chance here, but let's go ahead and turn to you all in the room. Anyone want to, the lights are pretty high, so I can't quite see. We have a question right here. If we could bring a microphone. The gentleman near the orange flowers. Everyone's near orange flowers. The gentleman right there. Could you stand up? Thank you. Welcome. Tell us your name.
Thank you very much. My name is Bernard Olayo. I work in Kenya. And thank you for sharing very wonderful perspectives. Reading about the great influenza, you see that even though the scientists were telling the US government that there's a disease here, because of the ongoing war and the need to keep the momentum going, they didn't accept it. And that allowed the influenza to spread a lot. In fact, they moved troops when science was recommending that they shouldn't. This morning, I was catching up with Kenya's papers, and there's an outbreak of cholera in one of the hotels. that is linked to a politician. But the government is saying there's no cholera, even though 47 doctors that were attending a conference in this facility were taken ill and are in hospital. So the question for you is, how do we prepare governments who are always slow to accept that there's an outbreak? Because if you're the government and you say, I have an Ebola outbreak, immediately the visitors will cancel their travel plans, and there's a risk to the economy. So how do we prepare them to act fast, as you have suggested?
Beautiful question. Thank you, Bernard. Prabhat first, and then Ngozi I'm interested in. Please.
Great. First of all, it's great to see Bernard. I worked with Bernard in Kenya many years ago. You know, one thing that you mentioned is that there is a question about official reporting from government reporting in a lot of settings, which can be sometimes, for various reasons, either censored or curtailed. And I think one thing that's very important is that there is so much information that comes in from people in communities, from social networks, et cetera, that we have to start recognizing is part of how we should think about what is accurate information for a response. You have to be careful with that, as I'm sure Ngozi will qualify, because it has to be verified. But we have to recognize that people and communities are part of that solution, and they can, and when there's that information sharing, I think some of the fear and some of the threat elements of this start to go down a bit. But I'll kind of pause there.
Right, good.
Sure
Ngozi, what are your
has-
thoughts to that point?
Yeah, I just have a different perspective, just thinking about it on a global scale. Like, that really is the role of World Health Organization, right? Like, to encourage countries to be transparent and to be part of this global health link, this chain, basically. And it's actually against the international health regulations to restrict air travel during an outbreak or an epidemic. And we did see that happen during Ebola as well, right? Different countries shut down their airports to countries coming, or from passengers coming from West Africa, as well as their land crossing. And that's a problem, because the international health regulations is this global mandate that all countries have agreed to protect the health of the world. And part of that is also ensuring, mitigating consequences to a country's economic situation during an outbreak. And so if the WHO really steps up and, takes up their leadership role and encourages countries to be transparent and to report when there's an outbreak, and if the WHO has the capacity to respond to that outbreak, then I think countries are going to be more secure, more able to report quickly. And as you said, Bernard, other countries should not be responding or reacting to situations like that. So,
Right. Agnes, and then other questions. Please.
Very well said, but totally inaccurate. Because WHO was totally inefficient, totally inexistent, and was totally underperforming. So if we wait for them...
Sorry, you're saying the WHO was?
WHO, yes.
Okay.
So we cannot count on that. In Ebola, they were absolutely inexistent. So, and not accountable, and still not. But education. Because people fear news just because they don't know how to manage it. And they don't know that telling the truth is the best way to create trust. When we had a suspected case in Rwanda, we said, do you believe tourists went away? No. You believe something shut down? No. People were reassured because we have the right reaction. And when there will be a danger for more people, they will be informed. So this is something we should teach in leadership program, and that's why we dedicate our time.
So I think Chris wants to jump in on this too, because we're talking about a really important point here.
I'll just say two things. Looking back at the summer of 2014, it is absolutely striking that the U.S. military decided to stand up an Ebola working group before the WHO declared an international health emergency. That is just striking. And that goes back to the panel's point that data is so crucial. So we're sitting on the joint staff, and we get the clearance from the president to go ahead and get deeply involved in the crisis. And I remember sitting in a room with the air planners from Transcom. We're trying to figure out, we're setting up an air bridge. Where are we going to push, 3,000 U.S. troops? Where are the logistical staging bases are going to be? We need, where are the ETUs going to get constructed? This is all data-driven, and we had hardly anything to go on.
Why? Why did we have hardly anything to go on?
Because at this point in the epidemic, we were canoeing data, if you will, from rural villages.
And you mean that literally?
I mean that
Getting
literally.
data from canoes.
We were marking bodies with stick pins. We were hand drawing maps. None of the resources that we now have today, thanks to incredible innovations and, for instance, digital tools, were there. So we were having to run and make enormous decisions of consequence at a time the epidemic was doubling every 3 weeks, with almost nothing to go on.
Heike, can I just add?
Please.
With tremendous respect to Dr. Agnes, what I was suggesting was what should be, right? WHO wasn't there, as Chris said. It wasn't there, but it should be. And that was a huge recommendation from the UN panel looking at the Ebola situation, as well as the Harvard and London School of Hygiene Tropical Medicine panel for recommendations for future outbreak responses. We do need a coordinated body at the global level. And right now, WHO is not up to where it should be. I totally agree with Dr. Agnes. And so we do have a lot of hopes on Dr. Tedros, who is the recently elected Director General for WHO. But all of us have to be, all the organizations, all of the governments, we all have to work together to ensure that something that happened like Ebola or like cholera in a hotel in Kenya, it's not hidden, so that we can react quickly to it. So.
Very good point, yes. Please, another question right here and right there. Let's take 2 questions in a row. There's this one, the lady in the stripes.
Hi, my name is Noor, and I work in Senegal with emergency operation centers in all of West Africa. My question is with respect to data being crucial and digital innovation. WAHO wants to have a database and a platform to share data. WHO wants to have one. The REDIS program of the World Bank is also trying to put together a surveillance program. So we have all these multiple programs that are trying to do the exact same thing. How can we avoid duplication of efforts again in global health? Thank you.
Great question. Yeah, I want to take, since we're coming up against time, I want to take 2 other questions. So we'll take 3 in a row so that we can make sure people have a chance. The woman in the white sweater, please, and then be next.
Hi, my name is Asia and I'm from Mali. I just to emphasize what Gozi said, I remember that during the Ebola outbreak, I was working in Senegal on something else, but I happened to be in the office of the civil protection when a Guinean student who was studying in Dakar, in Senegal, had Ebola. So he went to Senegal. He obviously didn't tell them he had Ebola so that he would get in, but he went to Senegal for treatment so that he would survive. And I remember that there was a lot of outrage about, putting Senegal to risk. And like you said, a lot of the neighboring countries closed their borders. So my question is also maybe directed to Dr. Agnes. How can we convince governments, neighboring governments belonging to the same union, that it is not very efficient to just close your border to basically prevent the epidemic to come to you? So I think it's also a question of mindset. And what is the organization that can do that? Is it the African Union? Is it the regional economic community? How can we really do it in an efficient way?
Thank you, Asia. And then we have one more question right here, and then let's see how we can respond. And I think we're going to have to.
What can we learn from what goes on in the developing world regarding healthcare workers in America, let's say in Harvard?
Great question. We just repeat it really quickly. Great question.
Oh, repeat it.
Yes, please.
What have we learned in the developing world regarding healthcare workers that we can use here in America in our own, in Harlem, let's say?
Great questions. Data, role of countries. Anybody want to jump in? Yeah, please.
I'll just jump in on the data question. There are dozens of data systems anywhere you go. It's same thing in New York City. It's same thing actually if you go to West Africa, if you go to Guatemala. One thing that we haven't done very well in public health is use modern technology design. So for instance, Atlas is not a new technology platform. On the back end, we have data engineers that can bring in dozens of sets of information that already exist, and then make sure that it gets outputted to a person in the way that they find sensible. And everything else can live in the middle, and somebody can choose to preserve it or consolidate it at their will. This is no different than if you looked at Google Maps or Waze. It takes in a ton of different information sources, and then it shows it to you in a way that's relevant to you. And one thing that I'm heartened by, again, is that we have a new generation of people that are interested in health because of events like this, because of raising awareness, that are coming to help us out and bring in some of the kind of methods that we don't even think about and making them normal in public health response.
Great.
And add to this, we can say that the world has managed to regulate car standards.
Core standards.
Huh? And we don't manage to regulate health information system. It's just a matter of badwill.
Yeah, really good point. Anyone else want to jump in on the 3 questions?
How to convince government
How to convince
not
government.
to close borders is to educate government to do good all across. Because if your country can be shut down because other countries doesn't tell the truth or etc., your role is protection. So education, skills transferred, and transparency. That's the way to go.
Beautiful.
Just add, I think some of this is shifting the value set, right? There's shame to report that cholera outbreak in the hotel. There's shame in Liberia to actually talk about it, including the fear of economic panic. We need to shift our social values around this. Reporting should be celebrated. Truth-telling should be celebrated. There's a TED Prize for dreamers. There's a Mo Ibrahim Prize for fighting corruption. There should be a prize for truth-tellers. Yes. And that governments who are willing to prevent, detect, and respond and tell the truth when something happens quickly.
Great. Beautiful. Thank you. Nice. Great. I think we have the one question on U.S. global learnings. Have that?
I think that another advantage we never talk about the community health workers is the fact that they create social capitals among the community. And what is dramatically lacking here. And if you have social workers, community health workers, you can call them whatever, they are going to fight solitude, depression, and create social capital in communities. That's something you can borrow. You have so many jobless young, bright people, and middle-aged people, and even old people. Use them.
Yeah, beautiful.
And I'll just add to that, which I think is spot on. In the U.S., we're taking a mind shift of when you're in a doctor in a clinic, you're not just thinking about the 20 people you're going to see that day, but the 2,000 people that you didn't see that day. How is their health? And you're not going to be able to do that alone. And so a health coach is now kind of, I think, a normal part of high-performing primary care. And then the question becomes, how can we utilize them not just clinically, but for the social capital elements, for driving some of the economic development, connecting with the other parts of what it means to be a healthy place. And we've really learned a lot from actually the structures that you've built in Rwanda, and it's how we're thinking about it at Mount Sinai and in Harlem.
Beautiful, thank you. I want to make a little plug. There's some wonderful sessions on global health featuring many of these folks up here, so please join us at those. And then also tonight at the Hotel Jerome at 5:30, we have the undaunted performance of the Aspen New Voices Fellows, many of whom are in this room, and Dr. Ngozi is one of those. But I really, it really comes deeply from our heart and from all of us at the Aspen Institute for all of you to share your brilliance with us. Please join me in giving a round of applause. Thank you.